This presentation will look at constipation in adults over 65 years of age. Constipation is defined as a decrease in the amount of stool when passes. The stool can stay in the bowels for longer periods of time, causing the bowels to absorb more and more water, which will cause the stool to be harder and harder and more difficult to pass. This presentation specifically focuses on the elderly, those over 65 years of age. Pathophysiological changes can increase the likelihood of constipation. And first we will look at the cardiovascular system for those over 65. Dietary choices can influence the amount of plaque buildup in the blood vessels of the heart. And over time, with a continued diet of high fatty foods and red meats, more and more plaque can build up, causing more occlusions when the patient is elderly. Also, after 65 years, the body has a decreased ability to pump blood. Changes in the heart rhythm, ventricular wall thickness, and diastolic filling patterns will actually decrease the ability to pump the blood. With a decreased heart health and higher risk for heart disease, it will influence patients to maintain a sedentary lifestyle, and activity can decrease your risk for constipation. So therefore, a more sedentary lifestyle increases the risk. Next, we'll look at the respiratory system. Those who are 65 years and older can actually lose height in the spine, which causes a decrease in the ability to expand the chest as far. Respiratory muscles can lose their strength, specifically the diaphragmatic muscles and the respiratory muscles, which can impede the ability to inhale or exhale as much. The cilia in the lining of the lungs doesn't function as well, and the amount of cilia can actually decrease as well. Cilia moves mucus, so with a decreased ability to move the mucus, more and more can build up, which can impede lung function. As far as constipation goes, respiratory function can be affected. Those with COPD or asthma or even chronic bronchitis can report being full more easily, which can contribute to being malnourished. Without a diet full of roughage and water, the bowels can become blocked, potentially causing constipation. Next, we'll look at fluid and electrolyte imbalances. The thirst sensation in those who are older can be decreased. They may not feel the need to drink as frequently. That can decrease their fluid intake, and dehydration can lead to constipation. Urine concentration, kidney function, and aldosterone secretion are all decreased with age. All of these regulate sodium levels, which influence hydration. Dehydration, as I've already said, can contribute to constipation. Harder stools are more difficult to pass. Also, the dining environment for the elderly can affect how much a patient takes in and how much they drink during a meal. Often older adults live alone and may have difficulty preparing meals or even grocery shopping. They can also live in assisted living situations. All of this affects how much is taken in by the patient. Next, we'll look at the endocrine system. Older adults are have a higher rate of metabolic syndrome, which includes hypertension, hypoglycemia, and hyperlipidemia. Calcium levels decrease in the elderly and cause a decrease in activity due to weak bones and poor musculoskeletal function. With weak bones, patients who have had a fall may not be able to move as well due to pain, and weaker muscles, they may tire out more frequently, decreasing activity. They also can experience greater hydration due to plasma osmotic pressure, decreased secretion of ADH, antidiuretic hormone, and impaired thirst sensation. Next, we'll look at the musculoskeletal system. As we've already spoken of with the endocrine system, bones lose more and more calcium, and that can cause them to be brittle and weak. And the muscles, also due to the calcium, can lose mass and are turned to fat. This decreases your strength and ability to move around as you age. Ligaments can become weaker and shorten, and synovial joints can lose their fluid, and cartilage can be worn down. All of those things can cause pain with movement. Also, loss of estrogen can increase the loss of calcium from bones, further leading to osteoporosis, specifically in women. So we'll look at sensory changes, specifically hearing changes. The cochlea as we age, which of course is very important to one's hearing, atrophies and decreases the ability to hear in the elderly. Not only does the cochleal function atrophy, but the area in the brain responsible for hearing can decline as well. Patients with hearing loss are actually reported to not be as ambulatory due to the inability to hear. They are more at risk and less safe when ambulating or moving around. So they're much less likely to be active or social. And as we've seen, constipation can come with inactivity. Hearing loss decreases the activity, and that can therefore lead to slower bowels and constipation. Next, we'll look at integumentary system. For those who are 65 and older, the sebaceous glands produce less sebum, causing drier skin. The subcutaneous layer, that's the fatty layer of skin, may thin, and that causes a decrease in the ability to stay warm. The dermal layer, which has blood vessels, can actually weaken and cause an increase in bruising. The rete ridges in the skin can flatten, which causes much more fragile skin. Specifically with the fragile skin, patients may not be as willing to move around as much due to fear of tearing their skin. And with the body temperature, they may not want to move around as much either due to wanting to stay warm in a warmer environment. Next, we'll look at gastrointestinal changes, which are very important in regards to constipation. Rectal sensation in those who are over 65 decreases. And what that means is larger amounts of feces would be needed to trigger the urge to defecate. And with a larger amount needed to trigger the urge, more and more feces stays in the bowels longer, which, as I've already said, causes an increase in the absorption of water. So the feces loses water and becomes harder to pass. The anal sphincter loses some of its strength, which can cause fecal incontinence. And women specifically notice a decrease in squeeze pressure when they age, meaning they can't push the stool out as easily. Women are much more likely to experience constipation, and this could be a very high indicator of why. Next, we'll look at the modifiable risk factors for constipation. So far, we've looked at the non-modifiable risk factors included in aging. Modifiable risk factors are diet, specifically increasing the amount of roughage, so fruits and vegetables, more fiber-rich foods, whole grains. Those will cause more fiber and more bulk and will push stool out easier. Also, the more bulky forming stool foods will increase the amount of water in the stool, also making it easier to pass. Identifying constipating foods and avoiding them. So constipating foods can be refined sugars, white breads, and red meats. Maintaining an active lifestyle, really even moderate movement. As we age naturally, with the musculoskeletal changes we've discussed, patients may not move around as much as when they were younger, but even just maintaining short walks can prevent the risk for constipation. Also, patients, specifically those who are over 65, may not be at a place where they can defecate as soon as the urge is noticed. They may be slower in their movements. They may be in a facility that requires them to call for help. And not defecating when the urge is noticed means that later they may not have the urge and they may not have that peristalsis to push the stool out. Next, we'll look at a chart that kind of pulls it all of the risk factors together. So we have modifiable risk factors, lifestyle, including a sedentary lifestyle, delaying the urge to defecate, and diet, so not eating as much fiber or taking as much hydration in. Some non-modifiable risk factors, so specifically pathophysiological changes, age-related changes can cause decrease in stomach acid, decrease in peristalsis, decreased sensation in the rectum, and specifically gender-related, women experience decreased anal squeeze pressure. And together, these can cause constipation, which can cause decrease in self-esteem, feelings of isolation, or embarrassment. So as far as treatment plan, we will focus on the modifiable risk factors. Individuals should try to promote a bowel regimen. So that means training the bowels to move at a certain time, specifically after meals. The peristalsis is triggered, so specifically after breakfast or dinner is the best time to try to defecate. So as far as a regimen goes, one can start the treatment plan by trying to defecate after breakfast or after dinner, or both, and whichever one produces a bowel movement, sticking with that. Low to moderate activity, as we've already spoken of, 30 minutes of walking, dancing, and the like. Consuming fluids to maintain hydration. Specifically, many people already know of prune juice or pear juice are really good options to promote bowel movements. Small amounts, too much sugar may not be a good thing, but patients can be encouraged to drink even if they're not thirsty, because as we've spoken of, they may not have that trigger to drink by that thirst sensation. So encouraging fluids may help to maintain hydration. A high fiber diet is important, as we've already talked about. Eating fruits and vegetables and whole grains that can provide more fiber, which will increase the amount of water absorbed in the stool and can cause a movement. Also, one can consider some stool softeners that will also pull more water toward the stool, making it softer and easier to pass. And next, we just have our references. And thank you for listening, and I hope that this will help you in deciding a plan for your patients to maintain bowel movements.